The following podcast is part of a certified educational activity titled The Therapeutic Transformation of Bladder Cancer, Understanding Immune, Targeted, and Antibody-Based Models for Patient Care, featuring Dr. Matthew Galsky from the Icahn School of Medicine at Mount Sinai Tisch Cancer Institute in New York. Access the entire activity and complete the post-test at peerview.com/EQF860. Downloadable slides and practice aids are also available.
Hi, I'm Matt Galsky from the Icahn School of Medicine at Mount Sinai Tisch Cancer Institute in New York. Welcome to this educational activity entitled The Therapeutic Transformation of Bladder Cancer, Understanding Immune, Targeted, and Antibody-Based Therapies for Patient Care. We're going to cover an expanding armamentarium of therapies for the treatment of bladder cancer, and our goal today is to explore some recent advances focusing both on immunotherapy and non-immunotherapy options, including FGFR inhibitors and antibody-drug conjugates. We'll describe what these advances have meant to patients as well as to their provider teams. This is a very exciting time in the treatment of urothelial cancer in general, and over the past few years, we've seen a number of clinical trials focusing on immunotherapeutic agents, specifically immune checkpoint inhibitors. We'll first look at these therapies in the metastatic setting, as this is where they were first established as treatment standards. So for the treatment of metastatic urothelial cancer historically, and over the past several decades, we really only had a few treatment options. We've had cytotoxic chemotherapy drugs, and most importantly, platinum-based chemotherapy has been a treatment standard. And that all changed around 2015 when we saw the first hints of activity with PD-1 and PD-L1 inhibitors in this disease. Those clinical trials initially focused on patients with metastatic urothelial cancer who had progressed despite prior platinum-based chemotherapy, and were large single-agent clinical trials for the most part. And those trials showed not that the majority of patients responded to immune checkpoint blockade, because unfortunately that isn't the case, but what these studies showed was that a subset of patients, and generally between 15 to 30% of patients, depending on the study, this subset of patients achieved responses to immune checkpoint blockade in the metastatic setting that were durable. And when we talk about durable responses in this context, sometimes these responses last years, which is really quite different than what we saw with therapies in this context in the past. On this basis, and on the basis of a relatively favorable tolerability profile compared to treatments that we've had for metastatic urothelial cancer in the past, many of these drugs received accelerated approval for the treatment of patients with metastatic urothelial cancer progressing despite prior platinum-based chemotherapy. With treatment established as a standard in that setting, the question arose, should we move these drugs even earlier? Should we use them as first-line treatment for patients who haven't had any chemotherapy in the metastatic setting? And there was a specific population that this was first tested because it really represented an unmet need, and that was the population of patients with metastatic urothelial cancer who were deemed quote-unquote cisplatin ineligible. We know that urothelial cancer is a disease of older patients. The median age of diagnosis in the United States is 73, and we know that many of our patients have age and smoking-related comorbidities, making platinum-based chemotherapy difficult, and cisplatin in particular contraindicated for a subset of our patients. And so this really represented a prime opportunity to study immune checkpoint inhibitors as initial treatment. There were two large phase 2 studies that assessed this question, IMvigor210 Cohort 1 and Keynote 052. These trials explored atezolizumab and pembrolizumab respectively, showing objective response rates comparable to even higher than what we saw in the platinum-resistant setting. Again, these responses were durable for the most part, and treatment was generally tolerated compared to what we see with chemotherapy, leading to the approval of atezolizumab and pembrolizumab for the first-line treatment of patients with metastatic urothelial cancer who were deemed ineligible for cisplatin-based chemotherapy. Importantly, both of those studies explored whether or not a biomarker, PD-L1 expression measured at the protein level, whether or not that biomarker enriched for the likelihood of responses to immune checkpoint blockade, as there was initial enthusiasm that maybe this would provide a tool to determine who should and who shouldn't receive these therapies. Interestingly, in the IMvigor210 study, there was not a marked enrichment for responses in patients with high levels of PD-L1 expression. In Keynote-52, there did seem to be a correlation between PD-L1 expression and responses with pembrolizumab. Importantly, while we talk about PD-L1 expression similarly in these two studies, different assays were used to measure PD-L1, including different antibody clones, different cut points for what was positive and negative, and different cells that were scored, immune cells versus tumor cells versus both. And so even though we talk about PD-L1 as a biomarker, we're really talking about different things depending on the assay that's used. However, the initial approval of these drugs were not based on restriction related to PD-L1 expression, based on the fact that responses were seen even in patients with low levels of PD-L1 expression. But this changed with the initiation of two large phase 3 studies that sought to test whether or not we should give immunotherapy alone to all first-line patients with metastatic urothelial cancer who hadn't received prior chemotherapy, or standard chemotherapy. And there was a third arm of those trials regarding combination treatment, which I'm going to speak to a little bit later. With both of those studies, and those studies are IMvigor130 and Keynote-361, with both of those studies, after the studies had been enrolling for some time, the Data Safety Monitoring Committees noticed that patients randomized to single-agent immune checkpoint blockade on both studies independently. Patients randomized to single-agent immune checkpoint blockade who had low levels of PD-L1 expression were dying at a faster rate than patients randomized to chemotherapy. And so the DSMB said we shouldn't randomize patients with low levels of PD-L1 expression to single-agent immune checkpoint blockade anymore. The studies were almost completed at that time. The FDA reviewed the data, and they ended up changing the label for first-line treatment for pembrolizumab and atezolizumab even before these phase 3 studies ultimately were completed and read out. So currently, the FDA label for atezolizumab and pembrolizumab for the first-line treatment of patients with metastatic urothelial cancer who are considered quote-unquote cisplatin ineligible is restricted to patients with high levels of PD-L1 expression in their tumor based on the respective assays used for both of those drugs. And we'll talk a little bit more about the results of Keynote-361 and IMvigor130 because these trials now have been read out and presented or published, telling us a little bit more about optimal treatment for metastatic urothelial cancer. Here you can see the schema of 4 trials poised to change first-line treatment of patients with metastatic urothelial cancer. And these trials really fall into 2 buckets in terms of the questions that they were trying to address. IMvigor130 and Keynote-361, as mentioned, sought to address whether or not we should give single-agent immune checkpoint blockade plus chemotherapy, or chemotherapy alone. Danube and Checkmate 901 asked a slightly different question. These trials asked whether or not we should give single-agent immune checkpoint blockade, an immune checkpoint blockade combination, that's PD-1 or PD-L1 blockade plus CTLA-4 blockade, or standard chemotherapy. The first 3 trials have read out their results. We have the results for Danube, Keynote-361, and IMvigor130, and Checkmate 901 continues to enroll. I'm going to speak to some high-level results from these studies, but importantly, a study that's really designed somewhat differently, not on this slide, but seeking to move immune checkpoint blockade earlier in the course of treatment for metastatic disease has been the study that has had the most impact on our treatment algorithms, and that is the Javelin 101 study. And this study asked a slightly different question. This study asked, what if we take patients who have already received platinum-based first-line chemotherapy, and after they've received 4 to 6 cycles of treatment, if they have achieved at least stable disease on that chemotherapy, why don't we give them immune checkpoint blockade right away rather than waiting until those patients develop progressive disease? Historically, we've given 4 to 6 cycles of platinum-based chemotherapy and then stopped treatment because we know if we keep giving that same treatment, then side effects start to accumulate, but benefit plateaus. So we typically stop after 4 to 6 cycles. What if instead of doing that and just waiting for cancer to progress, which it does unfortunately in the majority of patients, what if we start immune checkpoint blockade right away? So there are really 2 studies that assessed this question. One was a smaller randomized phase 2 study, which randomized patients with stable disease after first-line chemotherapy to pembrolizumab versus placebo. And that study met its primary endpoint, showing an improvement in progression-free survival. And then the Javelin 101 study, which was a larger study, randomizing patients to avelumab versus best supportive care in the switch maintenance setting. This study was a larger study and sought to define whether or not this switch maintenance strategy had an impact on progression-free survival and on overall survival. And this study met its primary endpoint, and you'll see the results, both the intent to treat population, that is all comers regardless of PD-L1 expression in the tumor, and in the subset of patients with high levels of PD-L1 expression. The trial met its endpoint in both populations, showing an improvement in overall survival. And this study really has led to a shift in the standard first-line treatment of patients with metastatic urothelial cancer, whereas we start with standard platinum-based chemotherapy as we have for decades, but now after 4 to 6 cycles, instead of stopping treatment and waiting, there is the option to switch immediately to immune checkpoint blockade. Back to these other 4 studies, which were really poised to change treatment standards by testing these even earlier questions. So instead of switch maintenance therapy, should we give immune checkpoint blockade right from the start with chemotherapy for the treatment of patients with metastatic urothelial cancer? Interestingly, IMvigor130 and Keynote-361 demonstrated relatively similar results, although there were some nuances in the statistical analysis plans of these studies, which leads to slightly different interpretation. IMvigor130 showed a significant improvement in progression-free survival with chemotherapy plus atezolizumab, the PD-L1 inhibitor, added to it. Keynote-361 didn't meet its progression-free survival endpoint. It didn't meet its overall survival endpoint. IMvigor130 didn't meet its interim overall survival endpoint and continues to be followed for the final OS analysis. In summary, however, the benefits of combining chemotherapy with immune checkpoint blockade thus far have been modest and haven't been sufficient to change standard of care. So right now, the switch maintenance strategy is preferred. How about doublet immune checkpoint blockade? Should we give CTLA-4 blockade and PD-1 or PD-L1 blockade at the same time? The Danube study addressed this in part. However, the primary endpoint of the Danube study was to assess single-agent immune checkpoint blockade versus chemotherapy, and that did not show a benefit with single-agent immune checkpoint blockade versus chemotherapy, nor did the other studies that I mentioned. A co-primary endpoint was to see whether or not CTLA-4 blockade plus PD-L1 blockade, that is durvalumab plus tremelimumab, leads to improved outcomes in all comers versus chemotherapy, regardless of PD-L1 expression. And that analysis didn't meet its primary endpoint. However, a secondary endpoint of the study was that same analysis in patients with tumors harboring high levels of PD-L1 expression. And in that context, CTLA-4 blockade with tremelimumab plus PD-L1 blockade plus durvalumab did show a benefit compared to standard chemotherapy. However, as a secondary endpoint, that's really hypothesis generating and not sufficient to change practice. So what do we make of CTLA-4 blockade plus PD-1 or PD-L1 blockade in this disease? Does it have a future? And there may still be hope for this combination regimen, this chemotherapy devoid regimen. And that's because the Checkmate 901 study continues to enroll and is really assessing whether or not this doublet of ipilimumab, the CTLA-4 inhibitor, plus nivolumab, the PD-1 inhibitor, leads to improved outcomes in patients with PD-L1 high expressing tumors compared to chemotherapy. That study hasn't read out yet, but we do have results from a phase 1/2 study, the Checkmate 032 study, which assessed this combination in patients with metastatic urothelial cancer. showing relatively high response proportions. And even though this isn't a randomized study, showing that the results with combination immune checkpoint inhibitors seem to be maybe a little bit better than single agent PD-1 blockade. So the results of Checkmate 901 are awaited anxiously, and we'll see if we can develop a regimen that is devoid of chemotherapy in the first-line treatment of patients with metastatic urothelial cancer. So have you seen the impact of immunotherapy on metastatic urothelial cancer has been quite profound and is now well established. But we know that there's a role for immune checkpoint blockade in earlier stages of disease as well. And because urologists are often the first medical specialists to see patients with bladder cancer, certainly the specialists to diagnose bladder cancer, it's important for urologists to have an understanding of these data as they emerge and to understand the roles for immune checkpoint blockade now and the potential roles in the future to ensure optimal multidisciplinary care. So let's take a look at some of the results in the non-muscle invasive setting and in the muscle invasive setting. One of the earliest approvals in really any type of cancer in terms of a disease state or disease condition in almost any type of cancer so far has been in bladder cancer, and that is the approval of pembrolizumab for the treatment of patients with BCG unresponsive carcinoma in situ. And this was approved in January of 2020 based on the KEYNOTE-057 study. And KEYNOTE-057 enrolled 2 cohorts of patients, and we've only really seen the results from 1 cohort so far. The 2 cohorts were patients with carcinoma in situ, which was BCG unresponsive, and then another cohort of patients with papillary tumors, that is high-grade papillary disease or T1 disease. The results of patients with carcinoma in situ that led to the approval are shown here. And the primary endpoint of this study was the complete response rate. And complete responses were achieved in about 40% of patients treated with pembrolizumab in this setting. This is a population of patients historically for whom cystectomy has been the standard of care. And so the development of a non-cystectomy option or a bladder-sparing option, for lack of a better term, has been sought after. And with pembrolizumab, the complete response rate is about 40%. And then among the proportion of patients who have a sustained response, a durable response, it's about 1/3 of the patients who achieve a complete response who remain in complete response greater than or equal to 18 months from the start of therapy. So similar to the metastatic setting, there are a subset of patients that achieve durable responses with pembrolizumab, and this does have the potential to spare or at least delay cystectomy in a subset of our patients. This concept was explored in a similarly designed study that was led by SWOG, and this was with atezolizumab monotherapy rather than pembrolizumab. This study was slightly smaller, designed pretty similarly, but the primary endpoint was complete response at 6 months by mandatory biopsy, and 27% of patients on this study had a complete response by that definition. So pretty similar results to what's been seen with pembrolizumab. How about the muscle invasive setting? There's been a number of studies exploring immune checkpoint blockade in the muscle invasive setting, a large number of phase 2 studies, and we'll talk about some of those studies in the neoadjuvant setting. In the adjuvant setting, however, in general, we've had to do large randomized phase 3 studies to answer the question because, of course, in the adjuvant setting, there's nothing to measure. And so the endpoints are really time to event endpoints like disease-free survival or overall survival. There's been 3 similarly designed adjuvant studies exploring immune checkpoint blockade. And all of these studies enrolled 2 unique patient populations. These studies enrolled patients with bladder cancer or urothelial cancers of the upper urinary tract who had undergone definitive surgical resection but were deemed at high risk for recurrence. And high risk for recurrence was defined in one of 2 ways. Either patients had previously received neoadjuvant cisplatin-based chemotherapy but had pathologic T2 or higher disease on final pathology or pathologic node-positive disease, or patients who had not received prior neoadjuvant chemotherapy, had pathologic T3 or higher disease, but who were deemed ineligible for cisplatin-based adjuvant chemotherapy. For those two patient populations, it's important to recognize that we have not had data to guide systemic adjuvant treatment in those contexts. These have been unmet needs. Both of these patient populations are at high risk for recurrence. And so this served as the basis for these 3 randomized studies. We've seen the results from 2 out of 3 studies so far. IMvigor10 was presented at ASCO 2020. Checkmate 274 was presented at ASCO GU 2021, and the Ambassador study continues to enroll. Notably, there is a slight nuance between these studies in that IMvigor010 and the Ambassador study both randomized patients between a year of immune checkpoint blockade versus observation, whereas the Checkmate 274 study randomized patients between a year of PD-1 blockade with Navolumab versus placebo. It was a placebo-controlled trial, which might have some implications in the adjuvant setting. IMvigor010, the primary endpoint was disease-free survival, reported at ASCO 2020, and this trial did not meet its primary endpoint for disease-free survival, and though the survival data was relatively immature at the time of the initial presentation of results, there did not seem to be a survival benefit with this approach either. Interestingly, the authors did an exploratory analysis, which was presented at the ESMO IO meeting this year. And what they did was take patients enrolled on this study and look to see whether or not they had minimal residual disease detectable in the blood by a circulating tumor DNA assay. And they looked to see whether or not atezolizumab benefited patients who had detectable ctDNA, a surrogate, if you will, for micrometastatic dissemination. And they showed that in patients with ctDNA negative disease after resection of their primary tumors, there was no benefit to atezolizumab. However, in patients with ctDNA positive disease, there was a benefit with adjuvant atezolizumab. This is an exploratory analysis. However, detection of minimal residual disease by ctDNA is emerging as an important treatment paradigm in the adjuvant setting in a variety of solid tumors. This may be the approach of the future, and these sorts of data are certainly going to be important to follow across all of these adjuvant data sets. How about Checkmate 274, the trial of Navolumab versus placebo? Again, a similar design to the IMvigor010 study, enrolled patients with those 2 high-risk characteristics, either prior neoadjuvant chemotherapy and residual disease, or no prior chemotherapy and cisplatin ineligible. Primary endpoint was similar in that it was disease-free survival, but there was a co-primary endpoint of disease-free survival in the intent to treat population and disease-free survival in patients with tumors harboring high levels of PD-L1 expression by the 28-8 assay, the assay specific to Navolumab in this context. The primary results were shown at ASCO GU 2021, and the study met its co-primary endpoints, demonstrating a significant improvement in disease-free survival in the intent to treat population with a hazard ratio of 0.7. In addition, a significant improvement in disease-free survival in patients with tumors harboring high levels of PD-L1 expression with a hazard ratio of 0.53. So really the first study in urothelial cancer to show benefit with an adjuvant immunotherapy strategy. Importantly, when treatments are applied in the adjuvant setting, it's important that they be as safe as possible. Certainly, these patients don't have detectable disease and they don't have a treatment-related burden by definition. And so we want to ensure that adjuvant treatments are well tolerated. And as can be seen on this slide, the adverse event profile with Navolumab was similar to what we see in the metastatic setting. And in many cases, the frequencies of adverse events was pretty similar to what's been seen with placebo in this study, with the exception of some events which are associated with immune checkpoint blockade, including pruritus and rash and other side effects that might potentially be immune-related. In addition to measuring adverse events by CTCAE criteria, patient-reported outcomes were also assessed on the Checkmate 274 study, and this included a range of quality of life assessments. So far, we've seen the results from the QLQ-C30, which is a global quality of life assessment, and both in the intent to treat population and in the subset of patients with PD-L1 high expressing tumors. You can see that there was no deterioration in quality of life with adjuvant nivolumab versus adjuvant placebo. Again, very important in the context of an adjuvant treatment. So adjuvant treatment with immune checkpoint blockade leads to improved outcomes based on the study of nivolumab in Checkmate 274. We'll await the overall survival results from this study in addition to the results from the pending Ambassador study. This really represents the first step into adjuvant immune checkpoint blockade or systemic therapy with immune checkpoint blockade in the muscle-invasive bladder cancer setting. However, we have seen a series of phase 2 studies test the concept of giving immune checkpoint blockade in the neoadjuvant setting prior to cystectomy. We know that neoadjuvant cisplatin-based chemotherapy is a standard treatment approach. However, we also know that only a subset of patients receive this treatment based on a range of considerations, including a proportion of patients being quote-unquote cisplatin ineligible. So there's been a desire to not only improve upon cisplatin-based chemotherapy in the neoadjuvant setting, but also develop treatments which are effective but can be applied to a broader range of our patient population. We've seen a number of phase 2 studies explore immune checkpoint blockade in the neoadjuvant setting prior to cystectomy. The PURA-1 study explored pembrolizumab. The Abacus study explored atezolizumab. Both of these studies were single-arm studies which were designed somewhat differently in terms of the nuances of the eligibility. The PURA-1 study involved 3 cycles of pembrolizumab. The Abacus study involved 2 cycles of atezolizumab. However, the pathologic complete response rates on these studies were quite impressive, with a pathologic complete response rate of 42% in PURA-1 and 31% in the Abacus study, really comparable to what we've seen with neoadjuvant chemotherapy in some studies historically. So these regimens certainly warrant further investigation. In addition to single-agent immune checkpoint blockade, we've recently seen 2 studies exploring doublet immune checkpoint blockade therapy in the neoadjuvant setting, showing pathologic complete response rates, which might even be a little bit higher, although the patient populations differed somewhat. And then we've seen a few studies combining chemotherapy and immune checkpoint blockade in the neoadjuvant setting, also with intriguing results. Taken together, these studies have led to launching a series of phase 3 studies to try and definitively address whether or not we should be giving immune checkpoint blockade in the neoadjuvant setting. And these studies include patients who are cisplatin eligible, testing the concept, should we give chemotherapy plus immune checkpoint blockade or chemotherapy alone in the neoadjuvant setting? And on those studies, there is an adjuvant portion as well, importantly. And then for cisplatin ineligible patients, a series of studies asking whether or not we should give single agent immune checkpoint blockade versus proceed with cystectomy alone. So these studies are really poised to change the way that we treat patients with muscle-invasive urothelial cancer, both patients who are eligible to receive cisplatin-based chemotherapy and those who aren't. So with that data accumulating to guide treatment of patients with muscle-invasive bladder cancer and non-muscle-invasive bladder cancer, let's look at a specific case. So Amanda is a 55-year-old woman who initially presented with hematuria. She has good renal function. She undergoes a cystectomy. Imaging and cystoscopy shows a sessile mass at the anterior bladder wall. She undergoes a TURBT. She's diagnosed with clinically localized muscle-invasive bladder cancer. She's referred to a medical oncologist and treated with 4 cycles of gemcitabine and cisplatin, undergoes a radical cystectomy, and surgical pathology reveals residual T3N1 disease. So what do we have to offer, Amanda? Historically, in patients who have received neoadjuvant cisplatin-based chemotherapy and have residual cancer in their bladder after such treatment, the standard has been observation. There have been some retrospective analyses exploring whether or not we can use different chemotherapy than what was administered in the neoadjuvant setting. And those exploratory analyses have showed mixed results, but we don't have a large number of non-cross-resistant cytotoxic drugs in urothelial cancer. And so that approach really hasn't become standard of care. Now, however, we have the Checkmate 274 results, which are directly relevant to Amanda. She received neoadjuvant chemotherapy. She has high-risk disease with pathologic features, demonstrating T3 disease and node-positive disease despite neoadjuvant cisplatin-based chemotherapy. This is a population of patients who would have been eligible for Checkmate 274, demonstrating a significant improvement in disease-free survival with 1 year of adjuvant Navolumab versus placebo. And so adjuvant Navolumab could potentially be an option for Amanda. It's important to understand that while immune checkpoint inhibitors have demonstrated benefit in patients with metastatic disease, muscle-invasive disease, and non-muscle invasive disease, there are side effects that are unique to these therapies that are critically important to be aware of. And they're important to be aware of because a range of different adverse events can be associated with these drugs. The side effect profile is very different than what we experience with cytotoxic chemotherapy, and it really takes close observation of patients to be able to make these diagnoses in terms of adverse events soon, so that intervention can be established. Immune-related adverse events with immune checkpoint inhibitors, again, can affect virtually any organ system, virtually any autoimmune disease that you could think of or manifestation of an autoimmune disease one can see with immune checkpoint inhibition. However, there are certain organ systems that, for reasons that are not entirely clear, seem to be more often affected. And these include the bowel, so colitis, the lungs, pneumonitis, the skin, dermatitis, the liver, hepatitis, and the endocrine system, endocrinopathies. And we see those range of side effects in patients treated with immune checkpoint blockade, although the likelihood of developing those side effects and the likelihood of them becoming severe is small. These wide range of side effects require vigilance in terms of patient follow-up and management. When do these side effects occur? Really also different than cytotoxic chemotherapy, which usually has a reproducible pattern in terms of onset of side effects. The immune-related adverse events can really occur at any time on treatment, and they can occur early, rarely after one treatment, but they can occur after as few as one treatment, and they can occur after years of treatment. The most common occurrence tends to be after about 4 months, although this also depends a little bit on the specific immune-related adverse event being seen. It's also important to note that unlike cytotoxic chemotherapy, where there's a range of side effects that tends to affect most patients, although the severity of those side effects is very heterogeneous, with immune checkpoint blockade, although not written in stone, most commonly it's not that a range of side effects develops in a particular patient, but rather that one side effect occurs in one patient, another in another patient, and so on. Yet another reason to become familiar with the range of side effects that can occur with these therapies. How do we manage immune-related adverse events? For events that are grade 1, that are the lowest severity, then typically we continue treatment and monitor patients, and there are specific guidelines depending on the organ system involved. For grade 2 events, the most common strategy is to stop treatment and then start steroids, systemic steroids, if there's been no improvement within a week. And then for grade 3 and 4 side effects, that typically requires hospitalization for specialty consultation and intravenous steroids. These are general guidelines. There are very specific guidelines for the management of specific immune-related adverse events published by a number of organizations, including ASCO, including NCCN, including SITC. And so it's important to consult with these guidelines for the optimal management of specific immune-related adverse events. So we've spoken a lot about immune checkpoint blockade for the treatment of urothelial cancer. Things to remember are that these drugs are associated with durable responses in a subset of patients, and so really have changed the way that we treat urothelial cancer across the spectrum of disease. I think we're going to be seeing a lot of these therapies earlier and earlier. And as these treatments get used more widely in the non-muscle invasive and muscle invasive setting, it's important for everyone to be aware of the indications for treatment for optimal multidisciplinary care, as well as the side effect profile, such that side effects could be recognized early and intervened upon early. There's a number of tools available to support patients with urothelial cancer and with bladder cancer that one should be aware of. And a great place for these tools is the Bladder Cancer Advocacy Network Beacon website. Included on the Beacon website, in addition to multiple resources for patients, are resources that can help the clinician, including the Beacon Clinical Trials Dashboard, which can help both patients and clinicians locate a clinical trial that might be most appropriate for their patient. As part of this educational activity, additional information about the Bladder Cancer Advocacy Network is offered as a practice aid, and I really encourage you to download this as a resource for you, your staff, and your patients. So we've spoken a lot about immune checkpoint blockade. How about non-immune checkpoint blockade options for the treatment of urothelial cancer? There's some exciting new agents, and let's talk about some of the new agents that have been explored in the clinic and already integrated into standard management of patients with metastatic disease. Genomic alterations occur frequently in patients with urothelial cancers, somatic alterations within the tumor. This has now been described in a number of comprehensive analyses. There are some genomic alterations that are more common in urothelial cancer than some other cancers and that are potentially quote unquote actionable. And perhaps the most important to date has been the discovery of FGFR3 alterations. FGFR3 alterations in urothelial cancer were initially described in a paper in Nature Genetics in 1999. And it took a while for that data to translate into treatments for patients. And that was for a number of reasons. One reason because it was noticed that these alterations are actually more common in low-grade, low-stage tumors. So that led to a little bit of confusion about whether or not this would be an adequate therapeutic target if it was actually more common in low-grade, low-stage disease like low-grade papillary tumors. The other area of confusion is that when these alterations occur in the germline, they cause the most common form of short-limbed dwarfism called achondroplasia. And that's because these alterations, when they occur in the germline, inhibit chondrocyte proliferation at the growth plate. So you have these alterations in the germline which inhibit cellular proliferation, and you have these alterations when they're somatic that are found more commonly in low-grade, low-stage tumors. And again, raising some questions about whether or not this would be a valid therapeutic target. But all the requisite studies in cell culture and other model systems were done to show that inhibition of the FGFR3 kinase, when it's constitutively activated with these mutations, inhibition of that kinase can cause inhibition of cell growth and tumor growth inhibition. And so that led to translation of this data into clinical trials. Interestingly, the first generation of trials with FGFR3 inhibitors wasn't that successful, and that was probably more a pharmacologic issue. The drugs just weren't potent or selective enough. But now we have more potent and selective FGFR3 inhibitors. A number of these have been tested in large phase 2 studies showing objective response rates with single agent therapy. These are mostly oral therapies administered chronically, as we do with other kinase inhibitors for the treatment of genitourinary cancers like in kidney cancer. Among the FGFR3 inhibitors approved for use to date is erdafitinib. And erdafitinib is approved for the treatment of patients with metastatic urothelial cancer who have progressed despite prior platinum-based chemotherapy based on the BLC 2001 study. Here's the design of the BLC 2001 study. This enrolled patients with metastatic urothelial cancer, again, who had progressed despite at least prior platinum-based chemotherapy. A few different dose levels were explored in this study, ultimately leading to the dose of 8 milligrams orally daily as the recommended starting dose. and the primary endpoint of this study was objective response rate. And erdafitinib, the small molecule inhibitor of FGFR, led to an objective response rate of 40% on this study. And you can see from the swimmer's lane plots that many of these responses are durable. And so really this is the first precision treatment for metastatic urothelial cancer based on a recurrent somatic alteration. And this really has changed the way that we treat patients with FGFR3 alterations. In addition, it has really led to routine genomic testing in patients with urothelial cancer, as it's critical not to miss these alterations given the potential for this treatment. Most of the FGFR3 alterations that we search for are hotspot mutations, are SNVs, with S249C being the most common. However, there are also some FGFR3 gene fusions that are relevant in urothelial cancer and have also been associated with responses to these small molecule inhibitors. A subset analysis of the BLC 2001 study was performed to see whether or not there were different clinical characteristics which could help determine which patients do best with this approach. And importantly, prior studies have shown that patients with upper tract urothelial cancers might be enriched in FGFR3 alterations. This subset analysis really showed that across the range of characteristics, upper tract versus lower tract tumors, prior immune checkpoint blockade, SNVs versus fusions, visceral disease versus not, all of these subsets of patients had responses to treatment with erdafitinib. And so this has really become part of our standard treatment strategy. Erdafitinib and other potent and selective FGFR3 inhibitors are associated with their own unique side effect profile. And these drugs cause a class effect of hyperphosphatemia. In fact, this is a pharmacodynamic marker for FGFR3 inhibition and has been used with erdafitinib as a justification to increase the dose if hyperphosphatemia is not occurring, but there are no other dose-related or dose-limiting side effects to dose escalation. And this is part of the labeled indication dosing scheme for erdafitinib. A number of other side effects can occur with this therapy, including skin and nail toxicity and eye toxicity. And we'll talk about this a little bit more, but the skin and nail changes tend to be onycholysis, hand-foot syndrome, paronychia, and the ophthalmologic side effects, central serous retinopathy, which is accumulation of fluid behind the retina and can cause blurred vision. So important for these patients to be monitored for skin and nail toxicity, and important for them to have a baseline and follow-up ophthalmologic examination while they're on treatment. The determination of whether or not patients have FGFR3 alterations historically and in the clinical trials to date has been based on testing of tumor tissue. We know that obtaining tumor tissue can sometimes take a bit of time in terms of finding that archival tumor specimen, pulling that block, and getting it tested for genomic alterations. ctDNA has the potential to change this, the ability to test for these mutations in the peripheral blood. And while we don't yet know if that could substitute for testing of the tumor specimens yet, there have been some exploratory studies, including the study which used ctDNA to assess whether or not there were co-alterations in other genes in patients' tumors that might render tumors resistant to single-agent FGFR3 inhibition. And this study, interestingly, showed some co-alterations which might be associated with resistance, providing rationale to pursue combinations of small molecule inhibitors to try and overcome this resistance. In addition to those strategies in overcoming resistance or to try and optimize treatment with combination therapies, there's also rationale to combine FGFR3 inhibitors with immune checkpoint inhibitors, because to date, data demonstrate that these drugs are non-cross resistant. And so when we combine these together, we might increase the likelihood that our patients are going to respond to one or both of the therapies. And you can see early data here from the Norse study combining erdafitinib with the immune checkpoint inhibitor citrilimab, showing tumor regressions in a large proportion of patients in this relatively small study. So further data from the NORTH study are awaited, and whether or not combinations of immune checkpoint inhibition and FGFR3 inhibition become standard of care in the future will await definitive studies. In the meantime, definitive studies are being performed to compare FGFR3 inhibitors with other treatments that we've used historically in the treatment of urothelial cancer, but hadn't had FGFR3 alterations to help guide treatment. So with the determination that these alterations are present in about 15 to 20% of patients with metastatic urothelial cancer, the question arises, what's the optimal space to integrate these therapies? Should we give these therapies instead of second-line chemotherapy? Should we give these therapies instead of second-line immune checkpoint blockade? And these questions are being asked definitively by the THOR study, which will help us determine the optimal sequence of therapies for patients with metastatic urothelial cancer harboring FGFR alterations. As already mentioned, the side effect profile with erdafitinib and other FGFR3 inhibitors is unique and requires a bit of experience, and there are some guidelines in terms of optimal management and some tricks, if you will. There can be mucositis and other oral-related toxicities, so good oral hygiene is critically important. There are skin and nail toxicities, and as mentioned, so early monitoring of the skin and nails and referrals to dermatologists and podiatrists becomes incredibly important. Hyperphosphatemia is a class effect of these therapies, as mentioned, and so important to consult patients regarding a low phos diet. There are a number of foods that are high in phos, including nuts, and so important to review a patient's diet, recommend a low phos diet, monitor phos closely, and then intervene with phosphate binders if the phosphorus level is getting too high. And this algorithm for management is clearly outlined in the package insert. And then there's the ocular toxicities, as mentioned, particularly central serous retinopathy. So critically important that patients see an ophthalmologist at baseline and then are monitored routinely while on erdafitinib. Central serous retinopathy, for the most part, is reversible with early recognition and cessation of treatment, but requires that close monitoring. The determination of whether or not patients might benefit from FGFR inhibition requires that their tumors be tested for genomic alterations. There are a variety of approaches to do this, including looking for FGFR3 alterations specifically, or larger next-generation sequencing panels. But as this alteration and others start to become actionable for the treatment of patients with metastatic urothelial cancer, it's critical that our patients have tumor sequencing to understand the full range of treatment options that might be available to them. To switch gears to yet another exciting new class of treatments for urothelial cancer, and it's important to recognize that FGFR3 inhibitors are a standard part of treatment for metastatic urothelial cancer now, because these alterations are more common in urothelial cancer than virtually any other solid tumor. So really represents really one of the first diseases where these therapies have been explored extensively. Similarly, antibody-drug conjugates, though they have been explored in some other solid tumors, really have made a huge mark relatively quickly in urothelial cancer. And we're going to talk about two antibody-drug conjugates in particular, which have advanced to late-stage development or are now commercially available for treatment. Remember, antibody-drug conjugates are based on the concept that we could take an antibody directed against a specific tumor antigen, link a cytotoxic payload to it, and allow that cytotoxic payload to be delivered specifically to that cancer cell. There are two antibody-drug conjugates in particular that have advanced to late-stage testing or are available for routine use, and these include enfortumab vedotin, which is composed of an antibody directed against Nectin-4, which is highly expressed on epithelial cancers, in particular urothelial cancer. And this is linked with a protease cleavable linker to the cytotoxic agent MMAE. This is a microtubule agent. So this protease cleavable linker allows the cytotoxic payload to release into the cancer cell once it's taken up through antibody binding. We also have sacituzumab govitecan, and this antibody is directed against an antigen called TROP2, and it's linked by a hydrolyzable linker to SN38, which is the active metabolite of irinotecan. What have these therapies demonstrated so far in urothelial cancer? Well, these have been tested in the metastatic setting, and the first large study to assess the activity of enfortumab vedotin was EV201, and EV201 explored two different cohorts of patients with metastatic urothelial cancer who had received both platinum-based chemotherapy and prior immune checkpoint blockade, and also a cohort of patients, cohort 2, who had received only immune checkpoint blockade as first-line treatment, because we discussed already that for cisplatin ineligible patients, single-agent immune checkpoint blockade has a role, and then received enfortumab vedotin as their second-line treatment for metastatic disease. Here's the waterfall plots for cohort 1, the patients who had received both chemotherapy and prior immune checkpoint blockade. And in patients with metastatic disease treated with those prior treatments, the response rate with enfortumab vedotin was 44%, really higher than we've seen with other therapies in this context. In addition to the likelihood of achieving a response, the response durations with enfortumab vedotin are such that this therapy received accelerated approval based on these early results. However, a confirmatory study was launched and completed, the EV301 study, which enrolled a similar patient population, patients with metastatic urothelial cancer who had progressed despite prior platinum-based chemotherapy and prior immune checkpoint blockade. And these patients were randomized to treatment with enfortumab vedotin. This is given intravenously on a 3-week on, 1-week off schedule versus older chemotherapy that we used to use, including taxanes, docetaxel or paclitaxel, or vinflunine, which is a vinca alkaloid available outside of the United States. So this study was presented at ASCO GU 2021 and has now been published in the New England Journal of Medicine. And this study met its primary endpoint, showing an improvement in overall survival with quote-unquote third-line enfortumab vedotin versus taxane or vinflunine-based chemotherapy, with a hazard ratio of 0.7 for OS and a hazard ratio of 0.62 for progression-free survival, really confirming what we saw on the large single-arm study previously. In addition, interestingly, the objective response rate with enfortumab vedotin in this large international phase 3 study really closely mimicked what we saw in the single-arm phase 2 study. So in EV301, the response rate was 40.6%. It's rare that we see that translation of that objective response rate from the smaller single-arm phase 2 study to the large international phase 3 study. So very important to see that, and that represented an increase in objective response rate compared to 17.9% with chemotherapy, including, again, taxanes or vinflunine. So really reinforcing the role of enfortumab vedotin as a standard treatment in our armamentarium. The adverse event rates with both of these therapies, with enfortumab vedotin and taxane-based chemotherapy or vinflunine, were really pretty similar. However, the side effect profiles are a little bit different with the antibody-drug conjugates, and we'll talk about that a little bit more. So with the really impressive activity of enfortumab vedotin as a single agent, the logical question arose, should we give enfortumab vedotin with immune checkpoint blockade? And so EV103 was launched, and this assessed whether or not we should give enfortumab vedotin plus pembrolizumab as first-line treatment to patients who have metastatic urothelial cancer but are considered cisplatin ineligible. And impressively, although a small sample size, and we haven't seen the updates of this study yet, but when it was presented initially, a relatively small sample size, but a response rate of 73.3%. You can see the waterfall plot here. An additional proportion of patients had tumor regressions that didn't meet standard criteria for a response. These are among the highest, this is among the highest response rate that we've seen with a regimen in metastatic urothelial cancer. And certainly we need to wait for more data, larger data sets, but this is impressive activity. And this regimen has been moved to a number of phase 3 trials, including trying to replace chemotherapy as standard first-line treatment for metastatic urothelial cancer, and is being explored in a few studies in the neoadjuvant setting, large phase 3 trials trying to displace standard neoadjuvant chemotherapy or trying to develop an option for patients who are cisplatin ineligible. How about sacituzumab govitecan? The development strategy or the clinical trials to date have really been similar to what we've seen with enfortumab vedotin in terms of the study designs and the patient populations that have been enrolled. We have data for sacituzumab govitecan in patients with metastatic urothelial cancer who have progressed despite prior platinum-based chemotherapy and immune checkpoint blockade. This treatment is also given intravenously on a day 1 and 8 schedule every 21 days. And what we see in the Trophy U01 study in patients with prior platinum-based chemotherapy who have progressed on such treatment, the response rate with sacituzumab govitecan is 27%. So again, higher than we would expect with older chemotherapy drugs in this setting. Maybe not quite as high as what was seen with enfortumab vedotin, of course, though it's dangerous to compare across different cohorts. These are relatively large phase 2 cohorts. You can see the waterfall plots here showing that in addition to those patients meeting criteria for objective response, again, we see this proportion of patients who don't meet that threshold but do have some tumor regression. So antibody-drug conjugates are active in this disease, these two therapies directed against Nectin or against TROP2. You can see the response durations with sacituzumab govitecan, again showing that some of these responses can be quite durable. And leading to the design of the TROPiCS-04 study, a definitive study comparing sacituzumab govitecan with chemotherapy in patients with metastatic urothelial cancer who have progressed despite platinum-based chemotherapy and despite prior immune checkpoint blockade, very similar to the enfortumab vedotin trial design, phase 3 trial design that I showed you before. So we await the results of the TROPiCS-04 study. As mentioned, antibody-drug conjugates have a little bit of a different side effect profile compared to standard chemotherapy, and this is dependent on both probably the target in terms of the antigen and dependent on the payload as well. And so with enfortumab vedotin, the side effects of note include peripheral neuropathy, hyperglycemia, and a rash. A rash is relatively common. A severe rash, however, can occur in a very small subset of patients, so very important to monitor for. Hyperglycemia, another somewhat unique side effect with this therapy. There are hold criteria to not administer enfortumab vedotin if the glucose on day of treatment is above a certain level. There's actually a cap on the dose of enfortumab vedotin to try and avoid these types of side effects. And of course, peripheral neuropathy tends to be cumulative and so needs to be monitored frequently. And dose reductions and dose holds are important in mitigating peripheral neuropathy with this therapy. With sacituzumab govitecan, we see a little bit more on the way of typical irinotecan-like side effects. So diarrhea, cytopenias, and a risk for febrile neutropenia. So growth factor support should be considered with this therapy. Strategies to manage diarrhea are critically important, like we use for irinotecan, and patient education and hydration critically important with that therapy. So a range of new therapies for the treatment of metastatic urothelial cancer. We've heard about immune checkpoint inhibitors. We've heard about FGFR3 inhibition, and we've heard about antibody-drug conjugates. How do we apply these in clinical practice? Well, here's another case, a 68-year-old with metastatic urothelial cancer who receives frontline treatment with gemcitabine and cisplatin, 4 cycles, has a partial response, then uses switch maintenance of avelumab, PD-L1 blockade, but ultimately has symptomatic progression confirmed by imaging. And so genetic sequencing, or genomic sequencing rather, of the bladder tumor shows the presence of an FGFR3 mutation, the S249C mutation. And so what type of approach would be appropriate for this patient? Well, this patient's progressed despite prior chemotherapy and prior immune checkpoint blockade. And really, we have a few treatment considerations. There's FGFR3 inhibition in this patient with an FGFR3 alteration. And there are antibody drug conjugates, particularly enfortumab vedotin, currently approved in this setting. Either of these treatments could be considered. I typically would give a patient who's received 2 lines of intravenous therapy, potentially a break with an oral FGFR3 inhibitor that is directed against a target that is particularly relevant to this patient's tumor. So FGFR3 inhibition, very appropriate in that patient with erdafitinib. How about a similar patient, but this time genomic sequencing reveals no actionable mutations? Well, clearly here, treatment with an antibody drug conjugate like enfortumab vedotin would be appropriate. And as described in this context, enfortumab vedotin is associated with an objective response rate of about 40%. And among the highest response proportions that we've seen with therapies in this setting, and certainly represents a standard and appropriate treatment option. So we've heard about a lot of new treatments for urothelial cancer. We've heard about advances in the metastatic setting, in the muscle invasive setting, and in the non-muscle invasive setting. We've heard about a number of new therapeutic classes: immune checkpoint inhibitors, antibody drug conjugates, small molecule inhibitors of mutant kinases. Each of these therapies is associated with a unique indication in terms of the patient population. Each is associated with a different mode of administration. Each is associated with a different side effect profile and different expertise in terms of managing those side effects. And so critically important to understand the full spectrum of therapies that are available for our patients. Critically important for multidisciplinary care of this difficult disease, and clearly critically important to know about these therapies to ensure that our patients are getting the optimal treatments for their cancers. Thanks for joining us today. In summary, we've seen the evidence that supports different approaches for the treatment of bladder cancer across multiple disease settings represent a number of alternatives for our patients. Of course, each approach comes with considerations that must be weighed by urologists, oncologists, and other team members, as well as the patient. All team members should be prepared to have discussions about treatment choices that best fit the needs of an individual patient and can serve as the basis for a shared medical decision. I'd like to remind you to download the practice aids associated with this educational activity as a resource for you, your staff, and for your patients. Thanks again, and we hope that you found this activity informative and useful for your practice.
This activity is accredited by Penn State College of Medicine. This activity is developed in collaboration with our educational partners, PVI, Peerview Institute for Medical Education, and the Bladder Cancer Advocacy Network. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EQF860. This activity is supported through educational grants from Bristol Myers Squibb, Gilead Sciences, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC.